Annual Dialysis Conference, presented by the Carl Nolf, MD, Division of Nephrology.
Good afternoon, everyone. Welcome to our first webinar of the Home Dialysis series for the 47th Annual Dialysis Conference. It's truly my pleasure to be hosting the first seminar. Today, I'm going to be talking about solo home hemodialysis. My name is Maria Camila Bermudez. I'm a nephrologist and assistant professor of the Geisinger Commonwealth School of Medicine. And I'm also the director of the Home Dialysis Program at our institution in partnership with DaVita. So today we have a fantastic group of panelists. I'm going to go through the talk, and then at the end, we're going to take some questions, and hopefully we'll have a nice discussion about this important topic. I'd like to introduce you all to Dr. Yeram and Dr. Malhotra. I will let them introduce themselves.
Hi, welcome everyone. We're happy to have all of you here. My name is Preeti Yoram. I'm a nephrologist at University of Missouri, Columbia. And I'm really excited to be able to do this webinar series with all these experts. So looking forward to it.
Hi, I'm Kunal. I'm a nephrologist at St. Louis University SSM Health. And I'm glad everybody's here. Hopefully we'll have a great session today.
Thank you, guys. So let's get started. Turn to advance. So I have no disclosures. The objectives of my talk are the following: to recognize the role of patients' preference in solo home hemodialysis, especially in the path towards FDA approval and therapy selection. I'll be going over how to overcome barriers from both perspectives, the patient and provider. And we're going to talk about how to identify and address these, especially for the implementation of solo home hemodialysis. And last but not least, I hope to promote a culture change towards patient empowerment and independence in dialysis care. The outline of my talk is as follows. We're going to talk about what is solo home hemodialysis, its beginnings, its path towards approval by the FDA, and also its implementation in the United States compared to globally. I'm going to be talking about why we should consider this therapy for our patients, how to qualify for this, how we do select patients for this modality, when to consider solo home hemodialysis. We're also going to be talking about how to empower patients to be safe and thrive in this modality. And I will be remiss if I don't include the patient's voice. So at the end, we're going to have a video with some of my very generous patients that are thriving on solo home hemodialysis that have shared their journey with us. So what is solo home hemodialysis? It's basically when patients perform hemodialysis independently at home without the assistance of a care partner or a caregiver. Patient is fully responsible for all aspects of the dialysis treatment, including care of the vascular access, setting up and operating the dialysis machine, monitoring their treatment, and of course, troubleshooting any issues that may arise. As you will hear during my talk, it's important to emphasize that this therapy needs to happen during the waking hours, and we're going to talk more about that. So here is the history of home hemodialysis over the years. We can see how it really was born in the late 1960s. As I'm sure know, is the very first way we started dialysis across the globe. Patients and their families were trained to take care of all tasks of dialysis in the comfort of home. Therefore, home hemodialysis was the prevalent modality in the late 60s. It was until the beginning of 1970s, especially 1972, when there was a sharp decline after the Medicare coverage of end-stage kidney disease. Then in 2005, we have a significant landmark, which is the FDA approval of solo home hemodialysis with the requirement of a care partner. Then in 2014, we have now approval of FDA for nocturnal home hemodialysis, now noting a change in pattern where care partner is required. However, just to be present, but not necessarily to monitor therapy. 2017 is really the landmark where we have the first time FDA approval for solo home hemodialysis, specifically for next stage as the first machine or equipment that received the approval. And for the first time, there's no care partner required. The current status of home hemodialysis in general in the US is about 2.4% prevalence, which doesn't seem like a lot, but I would share that in the past 10 years between 2012, 2020, there has been more than 60% increase in these modalities, so something really important and something to celebrate. The amount of patients that do it solo, it is unclear, unfortunately, is something that is not being currently monitored by large dialysis organizations. So now let's look at how we look compared to the rest of the world. So here, I like to share with you that, again, we have a prevalence of 2.4% in the US, with the standard of care being HHD with care partner, with solo being truly the exception, and many programs not offering this modality. This is compared with countries that actually lead in terms of HHD, where the standard of care is completely opposite, and patients need to prove independence to care for their therapy to qualify for HHD, with the exception being the training of a care partner. I like to highlight the case of Denmark. You can see a significant prevalence of 7%, and I do understand that if a patient is not able to run the therapy independently, they do not qualify for HHD in this country. And when you look at New Zealand and Australia with great penetrance of HHD, very similar to Denmark, the standard of care is independent HHD, providing training for care partners just during exceptional circumstances. So let's learn a little bit about how we achieved this important FDA approval in the country. So the Medical Device Innovation Consortium is a public-private company that partners with the FDA with the idea to advance approval of medical technology. In the case of home hemodialysis, especially for solo approval, MDIC facilitated the development of a patient preference study. So this is pretty pioneer work, right? Because they realized that home hemo is already so rare, solo home hemo even rarer. So conduct a study with such a small population and trying to look at potential life-threatening complications that are also rare pretty much would be impossible. So with this, basically a patient-centered case is needed for regulatory decisions in situations involving preference-sensitive decisions, where different patients may have varying tolerances for risks and a strong need for specific benefits, making it crucial for regulators to understand patient preferences for the device's benefit-risk assessment. I think understanding the beginning or the birth of this FDA approval is significantly important for us to acquire confidence and understand the importance of patients' preference in terms of solo HHD implementation. So now let's learn about this survey. So basically, 129 clinics that were not affiliated with any large dialysis organization. A total of 1,059 patients were surveyed with 142 responses. And what we are about to learn, I think, is quite impactful. So over 1 in 7 patients already were performing solo home hemodialysis, and others perform solo at least occasionally. We can see here, divided in the dark blue and light blue, with the dark blue were patients that were trained as solo, and the lighter blue, you have 85% of patients that were trained with a care partner, and of those, 16% of patients actually said that 16% of the times they actually dialyzed, 16% of these patients dialyzed solo at least part of the time. So in other words, our patients are likely doing it alone, even if they're not certified as solo. They felt that comfortable. So here they also said that more than 50% of HHD patients became comfortable performing treatment without help within 3 months of training. I think this is very, very important. And then even with a care partner present, the majority of patients felt confident to complete tasks without a partner. HHD patients have varied levels of concern about intradialytic hypotension and needle dislodgement. I think this is also important to recognize. We can see, recognize that perhaps these are the two situations where there could be a potentially life-threatening situation, right? A needle that comes out or an episode of high or low blood pressure. We can see here in the case of intradialytic hypotension that 19% of patients were very or extremely concerned. So it's not a significant proportion. I would think it's more, but it turns out it's not. Moderately concerned, about 33%, and between 33 to 15%, slightly or not concerned at all. And you can see the similar percentages for needle dislodgement. I'll go back here a little bit. When we look at actually objective data regarding how common needle dislodgement is, in the case of in-center hemodialysis, studies have shown that is rare. This potentially life-threatening complication happens basically between 14 to 91 per million treatments, so quite rare. And there's data in the HHD setting where it is 0.2 per 1,000 treatment, with cases requiring intervention even less frequent. And it seems that our patients have had the same experience, at least based on this survey. 60% of patients experience intradialytic hypotension less than once per month, and they actually shared that partners often do respond to help them. The majority of patients said that they have never experienced needle dislodgement during home hemodialysis. I think this is important to see. I would honestly say with my 11-year experience as a home hemodialysis provider, I do agree with this. I recall very, very few episodes where this happened, and we're going to talk about what measures we take to actually prevent that this actually happens. Established HHD patients have a strong opinion about solo, and I probably will repeat this twice. I think it's very impactful. 3 in 4 patients prefer solo HHD to in-center HD, even if the risk of needle dislodgement were to be 1,000 times higher. So when you think about that, it's quite important to recognize that the benefits of doing it at home overweight a potential risk, even if it were this high, which fortunately is not. And 2 in 3 patients prefer solo home hemodialysis to in-center hemodialysis, even if the risk of death were to be 50% higher. Very strong opinions. So it turns out that self-cannulation, which is one of the main barriers to solo HHD, which is the fear of needles, is our patient's right. CMS policies state that patients have the right to know and participate in their care and treatment to the extent they desire and their capabilities. And this, by the way, is not only supported by KDOQI guidelines, but also encouraged even by the ETC model, which actually incentivizes facilities to support patient autonomy. I would also mention that in-center facilities, as long as they have the capability to have a good trainer, should offer self-cannulation to patients, and they do not require specific certifications. So why to do solo? I think the case here is truly to recognize the known benefits of home hemodialysis. We know that it has shown to improve quality of life, increase energy and vitality, definitely improve post-dialysis recovery, also improve cardiovascular outcomes, sleep quality, schedule flexibility. But we also recognize that there's a lot of barriers, and I'm going to focus on the next part of my talk on the 2 main barriers to implement HHD, which are the lack of a care partner and fear of needles. So in this study called the IM Home Study, they surveyed all stakeholders. So they looked at understanding perceived barriers for home dialysis, not only in patients, but also care partners and physicians. What I'd like to highlight about this study is that I found interesting that everyone, all stakeholders, patients, caregivers, and physicians, we all agreed that one of the most important barriers is the insufficient home-based support. There's limited home-based support staff. There's many ways to interpret this, but as a home dialysis provider, and champion, I do interpret it as the lack of self-care skills, the dependence on a care partner for me as a patient to be able to do it at home. This was an Italian study that basically performed interviews on patients that started in center hemodialysis. They, in a unit that didn't have home hemo, patients were presented with home hemodialysis and its benefits. And both patients and care partners, a total of 22, they appreciated the autonomy and the benefits of HHD, but they expressed significant concern about the potential burden and personal sacrifice that HHD will impose on caregivers. This is a study that actually looked at reasons why patients failed therapy, comparing PD with home hemodialysis. And as we can see here, not only patient, but caregiver and burnout stand out. Once again, underlining the importance of self-care skills. But once we are successful and we're able to help our patients go home, the challenge now starts at keeping our patients home, right? We've learned also that when patients failed therapy, especially this was a large study, and they looked at patients that started hemo in center, transitioned to home, they were no longer able to be home and went back to hemo. We unfortunately learned that this failure of therapy was associated with increased early and late mortality. So arming our patients with all the skills that they're able to be independent, and knowing that one of the main barriers to implement HHD, but to stay in HHD, is either the lack or the burnout of a care partner, really makes a good case that self-care could be the way to go. This study I found very, very important. It was also exploratory descriptive study, and they asked 13 patients and their care partners that had done 6 months of in-center and now were at 6 months of home hemodialysis, their experiences. The goal of the study was to inform strategies for screening, training, and support to improve retention in home hemodialysis. They identified 4 profiles. You can see in the dark blue couples that were thriving, in orange patients that were surviving, in green patients that were martyrdom, were struggling, and then in the light blue, patients that were seeking another options. The seeking another option was just 1 patient, and patients that were thriving were 5 patients. What they found is that overall, all patients that were doing home hemo felt better. They definitely were doing a lot better, but they also found that patients that were doing more self-care tasks, particularly self-cannulation, were more likely to thrive, regardless of which profile they belong to. Once again, highlighting the benefits of self-care. This was a sub-study or analysis of the frequent hemodialysis trial, and they basically also found that patients feeling as if they were a burden was linked with worse depression and poorer quality of life. So now I'm going to switch gears to patient identification. How do we select patients that are appropriate for solo home hemodialysis? As you can imagine, this is a complex process. I like to highlight the importance of multidisciplinary team and the following steps. So the first thing is to make sure your patient has cognitive and physical ability to learn the procedure, to follow instruction, to be able to maneuver the machine, especially if it's cannulation. You have to take into account what is the location of your access, whether it is a catheter, a fistula, or a graft. Are they able to access their access appropriately? Patients need to be proven to have self-care capacity and motivation. Also, very importantly, medical stability. These patients obviously need to be fairly stable. This is in my experience during training, which is usually in my unit about 5 to 6 weeks, give and take, is enough time to really recognize if patients are suitable. This is where you really get to know your patients during training and analyze all of these important things. Then, of course, the suitable home environment that obviously apply for all home therapies. The psychological support, I could not highlight this more, even though you're perhaps doing it alone without a care partner. Our experience and published experience is that having that psychological support is very, very important to be able to stay in therapy, whether this is in the form of family, your care team, in the form of different care partners, like, for example, caseworkers, anything like that is very important. And of course, ongoing education. These are patients that need to be in agreement to continue to be learning and to be part of continuous education and competency checks. So I'd like to introduce you to this tool. You can download it from the Home Dialysis Central. Large LDOs have the same tool with their name, and it's basically what is called a partner agreement. But what really is divides home hemodialysis in 20 different items or needs that are required to conduct therapy. And this is something you can, like a survey, you can deploy to your couple, your patient, and your care partner, and for them to identify how much percentage of each tasks they are doing, whether they do it independently, whether the partner takes care of it, or whether they do it alone. This is a great tool to, number one, sort of diagnose where your patient's at, but also to encourage growth, to promote independence, to maybe even come up with milestones. This has been something we've been doing for several years now, and it really has been helpful in making sure we have a balanced proportion of tasks, and you take care of the care partner and make sure they're also not burned out. But again, you try to motivate your patients and help them acquire more skills. So how do we implement Solo? What are the specific points or logistic points for patients to thrive and do it safely? So I'm going to go over what's called the contract or physician-patient agreement. We're going to talk a little bit about the machine, specifically about safety devices, specific points about the prescription, and of course, the importance of continuous and close monitoring. So this is really a case of shared decision-making. You as a nephrologist are going to have to be the ones with your patient, with the help of your team, your nurses, your social worker, but eventually would be you as a physician with your patient making the decision whether solo home hemo is appropriate. So this agreement is going to include the increased responsibility the patient has. I always tell my patients that they're not only my patients, they're my partners, right? So it has to be a good understanding of this being the case, that they're going to agree to have extensive training and retraining if necessary. The safety and emergency plan needs to be well planned. Adherence to a sleep cycle assessment. There's many practices in this regard. I mentioned earlier for solo home hemo, it has to be done during the waking hours. There are practices and even states like Massachusetts that I believe do mandate official sleep study performances just to assure that the patient is not going to fall asleep in the middle of treatment. You want to make sure it's clear that there's going to be ongoing monitoring and continuous clinical evaluation, physician oversight. And as I mentioned, some states have different regulations, specifically Massachusetts, where physicians have to request waivers in order to be able to provide solo. In this slide, we can see all the fantastic new machines that we have. I'm sure most of us are familiar with NextStage. I like to note that this is the most commonly used machines in home hemo in the United States. The Versus, the newer version, looks similar, but now it has basically a guide, and it has an iPad that basically facilitates transmission of the flow sheets and patients' treatment settings into the web. This has been instrumental for the care of home hemo patients, with actually data showing improvement in survival of the therapy or therapy retention. You also have the capability of doing telemedicine on the moment. We utilize it a lot, especially for our solo patients. They basically just call the unit and there's someone in the team present via the iPad during their treatment. This is the Fresenius 2008K at home, Tableau, Quanta, all of them, I believe, maybe except Quanta, approved for solo, but hopefully Quanta soon. It was just recently approved for HHD. And I thought it would be fun just to show the Neo Kidney, which is just undergoing clinical trials in Europe. So these are some of the safety devices specific to next stage that are required for patients to be able to do solo home hemodialysis. So we talked earlier, one of the main fear, it would be dislodgement of a needle or detachment of the cannula in the catheter. So we have the fluid leak detector. Here is going to be underneath the filter and also underneath the cycler. In case there's any break in the system, is going to detect leakage and alarm. We have the red sense. It really, really works. It's basically a sensor that is going to be located right on top of the venous needle. And that also goes and applies for catheters. There's one that is going to be for catheters. And I just mentioned the role of remote monitoring. Clinics have different ways to do remote monitoring. It's challenging to have a nurse present at all treatments. But as I mentioned, there's many ways to do this with the new system and the ability to do telemedicine. There's other strategies that we utilize. Again, you want to instruct your patients to dialyze during waking hours. We tell our patients to make sure that their support system knows when they're on treatment. So there's many different ways we know patients are not alone, even though they're independent. Of course, taping the needles properly. Hopefully, many of you will join us next year at ADC. We're going to have a session where our fantastic nurse educators will go over all the strategies we have to teach our patients how to secure their needles properly. These really, really work. I have to say, it's really a great safety net. Then in terms of solo prescription, I think this is extremely important. I mentioned earlier, you want to make sure your patient is hemodynamically stable. The prescription is recommended that is gentler. By gentler, it's specifically related to ultrafiltration rate. We are all probably familiar with the fact that anything above, 10 ml per kilo per hour, especially in the home setting, is not recommended. It's associated with cardiac stunning. And there's incoming data actually telling us that even gentler is better, which is intuitive. I will share that in my practice, all my solo patients have ultrafiltration rates between 0.5 to 0.8 liters per hour. So, it's something that is fixed on the treatment that they are instructed to do not modify. And, it's part of my oversight to make sure that is the case. Once again, emphasizing this has to be during the waking hours. That also means no naps, discourage dialyzing late in the day, and treatment should happen in a chair or a recliner, discourage, of course, a bed. So I wanted to just show you a little bit. Once again, we're going to go over more of these during ADC, during our sessions. But I just wanted to emphasize that really believing in the part of self-care, us acting as active leaders, helping our teams to really change culture does work. I like to share the evolution or the progress that my unit has undergone in the last 10 years. We started in 2011 with about 8 home hemodialysis patients. As you can see here, they all had a care partner. It was a requirement. We did not have any solo. And as we move to a process towards patient-centric care, we are now at 34 patients. And as you can see here, and I really want to emphasize this, we have now a patient with significant degree of independence, even if they have a care partner. So we have HHD with a care partner here, around 18 patients, solo HHD with care partner, around 13 patients, and we have complete solo without a care partner, a total of 4 patients. I will also highlight that our solo care without care partner and solo with care partner, with the solo without care partner, all of them have fistula, they all self-cannulate. And the ones that do independent HHD with a care partner, 90% of them also self-cannulate. So they take care of cannulation even though they have a partner. So now, as promised, I have 3 of my patients that were very generous and they videotaped themselves sharing a little bit of their journey, basically a message for us as providers about their experience in solo. So let's listen to what they have to say.
Hi, my name is Shaniqua. I'm 35 years old. I am currently doing at-home dialysis with Dr. Bermudez and her team. I've been home for the past year. I did start off in center and I did do the PD. However, both of those took a toll on my body that wasn't positive. So I was able to come home once I was trained in center and be comfortable and safe in my home. So let's talk about it. So once I was trained how to poke my needles, which is really, really simple, it may sound scary, but you can do it. I do it solo. If you have a partner, great. If you don't worry. This process is smooth and easy.
Hello, my name is Jessica Hummel. I am one of the doctor's patients, and I'm here to take a couple of minutes of your time and to go over my experience with dialysis and the safety measures that go along with that. First of all, I've been on dialysis a total of 12 years. I did 10 years in center, and then I am currently doing home hemodialysis for almost 3 years. I enjoy doing home hemodialysis. It gives me more freedom. I can work in the morning and do dialysis at night and work around my schedule. Also, safety and precautions are a big thing you have to watch out with hemodialysis at home. Only because if you have a catheter like I do, the number one risk is infections. But if you are certified, like I am, through Dr. Bermudez at my dialysis center, and you take the right safety measures and take care of your catheter or your fistula, you should not have any trouble with infections or anything like that. Another safety measure you have to look out for is low blood pressure. There were times where I did have low blood pressure during treatment, and I know the techniques to give myself saline to bring that back up. If I also can do it at home by myself, but if I need help, my husband is right there with me. If I have any questions or need help grabbing something, he will gladly be able to do that for me.
Hi, I'm Melanie. I'm a former home hemodialysis patient. I did it solo with the help of my nurses, the support of Dr. Bermudez, my nephrologist, the support of the staff at DaVita, the nutritionists, the technicians. They were all there for me to answer any questions. And a lot of times the technicians were a shoulder for me to cry on, as well as the nurses. I keep in touch with them still. I mean, I don't know. Looking back on it, I would never choose another route. I didn't qualify for peritoneal, and I'm definitely afraid of needles. So when the doctor told me that she suggested home hemodialysis for me, because I was very active and I was capable of taking care of things myself, my husband, he figured out after the first day that he just wasn't going to be able to cannulate me. He just wasn't going to be able to. So I did it. I learned to do it on my own. And when I left training, I was certified as solo. And I truly believe the staff and the policies at the dialysis center, as well as my nephrologist, they all played a very, very important role in making sure that I was so confident when I came home to do my treatments. It was almost as if I was a nurse myself. I felt like I felt like a master cannulator. I don't know if anybody would want me to stick a needle in them, but I could do it to myself. So please don't hesitate to talk to your patients about it and actually get their opinions. Maybe they want to look into it. Maybe they want to visit a center and see what it's like. Thank you.
Very good. So then my last slide truly has few takeaways. Solo home hemodialysis is a proven modality with a long history, widely adopted in leading countries. US policy shifts have hindered self-care practices, but now there's renewed support from government and our professional organizations. Care partner requirements can limit HHD access and retention. Solo HHD can fill this gap. Successful solo home hemodialysis requires multidisciplinary teamwork, proper patient selection, safety measures, comprehensive training, and close monitoring. I truly believe, and I guess my message is that it is our responsibility to offer self-care options to all of our patients and to empower ourselves, our teams, and of course, eventually our patients towards different degrees of independence to their capabilities. So that's the end of my talk. So thank you so much for listening. At this point, we would like to take some questions. So I think you guys can go ahead and type them. I believe there's a section at the bottom of the screen.
There are already some questions,
Oh,
Maria.
perfect.
This
Okay.
was fabulous talk. I learned so much from it. And first of all, congratulations for developing such a successful and robust program. I know it takes a village to, get this running. You just can't wake up one day and say, I'm going to start a solo home hemodialysis program. It takes a lot of effort, planning, ironing out all the policies, procedures, and we're only going to scratch the surface. And hopefully, people can come to ADC to learn more about this and maybe talk to you one on one in person. But we'll take some questions in the chat. So the first question is there any specific age group study suitable for solo HHD?
That's a great question. Not to my knowledge. And as I probably briefly mentioned, there's really not a lot of studies about solo HHD practices. I would just say it's a great question because what I can take from it is that I would emphasize the importance of cognitive ability and skills, abilities for patients to be able to maneuver their therapy. A significant challenge would be, and not just for solo, but home hemo in general, even for care partners, as they grow older. You have to be very mindful to be reassessing any potential cognitive changes. With my experience, my patients are younger. As I mentioned, they have to be a little more selected. But I would share with you that in the home hemo experience, because patients truly do great, and we now have patients that have been doing it with us for 8-9 years. We are seeing patients aging and developing cognitive changes that come with growing older, not just on the patient but on the care partner. So I think great question. I hope I answered, fairly, but I do not believe there's specific studies to my knowledge.
The follow-up question is what is the schedule for lab review? Is it similar to regular monthly labs? And
that's correct. So same thing. We do labs monthly, and of course, same thing with regular home hemo or assisted home hemo. If they need more frequent hemoglobins, that's the case. Everything is the same. They also draw their labs at home. They centrifuge them. They send them. So everything is equal for patients with or without care partner.
If you have a patient who is like in a rural area, can the labs usually you do it local labs, or do you require them to come to the central lab?
So where I'm located, if you're not familiar, I'm rural. We're in central Pennsylvania. I have many patients that actually have to drive quite a bit and they don't have any local labs nearby. So it depends. We try to accommodate to our patients. If they have a FedEx, usually FedEx picks the labs in their home. Some patients prefer just to drop the labs at a FedEx facility. But to be honest, we kind of monitor these patients more closely. So many of our solo patients would come to our clinic more than once a month. And they would come perhaps twice a month. And sometimes they just bring the labs with them and we just facilitate that for them. I wanted to mention, because I didn't want to forget, one of the things that is not a requirement, but it's something I've established in my practice. It might be a requirement in Massachusetts. They have a very specific guide, which I like, is that patients that are solo needs to be seen once a month in person. So the rule about telemedicine is discouraged, especially for these patients that require a little more close monitoring. That might vary per practices.
Yeah, and then the next question is perhaps not specific to solo, but in general, who would be the communicator between patient and MD? So, how is communication handled and monitoring handled?
So I'm sure that also will vary per practices. I can share my personal experience. My patients have full direct communication with me and all the members of our team. Regularly, they will communicate initially with the nurses, and then, they of course will pass it along with me. But we have a good system that our patients know that one of the members of the team, including myself, will always be available. The next stage, iPad, the system I mentioned, has a setting that I absolutely love. And what it is that patients, they have the iPad and they're actually putting their vital signs in there. They actually can send us messages during treatment. So that's something that I have found extremely helpful. I do encourage them, by the way, to talk to me through messages. They tell me that they feel they accompany, and it's not unusual. I would get a joke. I really enjoy it, but they will tell me there if they had an issue with cannulation, if they had to, for example, insert the needle twice before they were successful. The little things that will happen during a treatment that I want them to know, that I want to hear about. I think that has also been very helpful because they know I'm reading that the team is listening. If I see something I don't like, they expect a phone call, right? Because we have availability of all the details about the treatments. So you have to have a very structured teamwork, which includes huddles. We meet every Tuesday, the whole team, and we go over all the patients. And we have a very fast and efficient huddle to go over big things, including communication, phone calls the patients did to the team or messages they send through the system.
I think the next question is also very non-specific. Any specific concerns about IV drug use?
I would say that would be a concern for all of our dialysis patients. If you think about it, I would definitely will not be comfortable, obviously, with someone that could have impairment in their cognition, right? So that would disqualify a person for any form of home therapy or self-care. So I guess, yes, that would be a reason, in my opinion, probably everyone's opinion, not to consider home therapies, generally speaking.
During the treatment, if a patient requires medications, how would that work out?
Yes, so they're trained, similar to home hemo. Patients undergo training, so they're able to self-administer certain medications. So we're specifically talking about Venofer. They will know how to do that. They can give themselves Epogen or erythropoietin or Mircera, even though we facilitate this for our solo patients for the most part. So we often just administer these when they come to clinic. But I do have a few of those patients that are very proficient and they're able to do that. I recently, Shaniqua, our first patient, who's pure solo, she recently had osteomyelitis and she required long-term antibiotics for 6 weeks. And we trained her how to self-administer vancomycin. And that was amazing. I mean, she was able to do this completely alone, of course, with more than one home visit from our nurses. We were very much present, but she was fully proficient to do so.
Okay. Well, thanks, Amit, for your question. The next question is from Cheryl Kress. What do you do when patients get lax and stop using leak detectors, start napping, and all that?
Best question from the best nurse. So it's gonna happen, and that's why I love this question. Once you dive into home hemo world, partner or no partner, I think we understand better how our human brain and our behaviors are. My analogy is always gonna be when I started driving. When I first finished my driving course, I was the best driver in the whole world. I was following all the rules and I got comfortable, and I'm sure I became more lax. So we see these on and on and on. Our patients will become so comfortable. I share with you the survey, right? We see it all the time. I think it's on us I think we need to be really, really on top of these patients. I would say with my solo patients are more on top of it. Fortunately, I have had just one situation, specifically exactly what you mentioned, Cheryl, was a patient of ours that for some reason, and probably happened more than once, wasn't wearing the red sensor, the red sense, and she actually had an episode of bleeding. Fortunately, nothing happened. She was able to troubleshoot it, but again, this could have been life-threatening. So truly, it's about re-education, patients taking responsibility. We talked about how, our patients that do home therapies, partner, no partner, this has been looked at. They do have a threshold to tolerate risk that is probably higher than patients that are not willing to do it at home. So you have to balance all of these things. And at the end of the day, just to try to really reinforce and monitor and closely follow your patients.
Right. Well, thank you, Camila. I'm going to just take over for the next few questions. And just as a follow-up to what you mentioned, do you ever do you have to tell your patients at each visit, and I'm assuming you will ask them, are you doing all your, safety measures? Do you ask them in, every time you see them? And
100%, yes.
does anyone ever say no, or?
Honestly, the honesty, and it's not like I have a ton of patients, right? But the 4 solo that I have to say, we're very grateful that they really have proven to be great communicators, and we really have developed that partnership I mentioned before. And that's something that builds with time. I was fortunate to have known 2 of these patients for a long time, so it was just an easy relationship. But again, I think there has to be an agreement and a belief that we've been honest with each other. Patients often will be honest, sometimes they won't be. That's the reality. Yeah, and it's a risk that honestly not only the patients but us as providers are willing to take.
Yes. But do you ever have to tell them every time, if you don't, this is the worst case scenario, you have to remind that every time, or?
We do that every time. And I think
Okay.
that's the focus of clinic. And I didn't talk much about it, but one of my patients mentioned the importance of infections precautions, for example. So, red sense, the importance of mupirocin if they're doing buttonholes, proper mask wearing when they're doing, access, all of these things need to be reinforced over and over and over. And patients get it because you're doing it, you're saying it so much, Preeti. I know your question goes to probably also encouraging us to do that. I think that's extremely important. If you don't talk about it, patients think it's not as important. And I could see patients saying, oh, you didn't tell me that, right? Because, we have this contract, but you'll forget whatever they sign. Honestly, I don't really care about that paper because what you said, you just have to continue to.
Who reads the contract, right? And Lisa has a question about that, and it's wonderful to see all the seasoned HHD nurses and in this talk. So thank you all for joining. I see Cheryl, Lisa, Beth, and Vandana as well. So thanks for joining today. So Lisa asked, do you have a written contract for your patients? And then she also, I think, said, is this contract different from consent to treat?
So yes, so this is different. And I do believe this is a CMS requirement. So I talked a little bit about the patient physician agreement. States will have different regulations, but for the most part, I do believe that this is a requirement. And this is literally, and I make it very glamorous. The moment I sign this with my patient, I make it that is a session where we go through all of these things together. I make it impactful so they do understand that it's a huge responsibility, that I'm trusting them the same way they're trusting me in all of these important points. But to answer your question,
it's a privilege, right? It's a privilege to be able to.
Yes. And yes, it's totally different, and it will have specifications related to they need to commit. Once again, I said it 10 times. They need to commit to do this during the waking hours. I could not emphasize that more. Similar to not wearing the red sense, I could see patients dialyzing too late. Actually, I didn't have the opportunity to share one of my patients' experience, which was actually the very first patient we ever attempted solo, and we failed. However, he still calls us. He loved the experience. But what I wanted to share with him is that he was a young man, a football coach, mastered self-cannulation, highly intelligent. But what happened is that he started to feel so much better. He took on more jobs, and then he was busy all day, waking up at 4 in the morning, going to coach, returning home late. By the time he set up, he was starting therapy at 10 p.m. And we can all imagine how that looks like, right? You're by yourself, you're tired, you don't have tolerance for alarms, and what I started to see is that he was avoiding therapy, short, he too many alarms, he would just get frustrated, go to sleep. Eventually, we decided that solo was not the right thing for him, and he actually returned in center. He's now transplanted, doing great. He looks back, he's an advocate for home, and he tells us that if he could go back, he would have not been like that, and he would have taken the benefits that home really provided. So I think that's also important.
Mugdha has a question. If a patient is interested in home hemo solo, where do I refer them for training?
So that depends on your area. I do believe that majority of programs do not offer this. I honestly think, and I just speak from my own experience. When I started home hemo, I shared with you a little bit. I was given a perfect program. Everyone had a care partner. I was highly selected. I wasn't comfortable at that moment in my career to take on this. That tool that I share with you about, the understanding how much the partner does, how much the patient does, is something that I instituted for my own growth and to understand my practice patterns. So we started to just deploy this questionnaire on our patients. And I was pleasantly surprised to learn that my patients were doing more that they were trained to do and that I realized they could do. Over time, we literally, as a team, we decided we were going to get that as a goal, literally establish milestones in our patients to try to help them acquire skills they didn't have to, try to achieve independence, even if they had a care partner. I'm all about protecting the care partners. Happy wife, happy life, and vice versa, right? So it really became very inspiring. And then I would share with you that our status quo right now is that our patients are going to be motivated to put their own needles. We start with the patient. If that doesn't work, we go with the care partner.
Yeah. But you're right. I think, I did a survey of a group of nephrologists, I think a couple of years ago, about perceptions on home hemo without a partner. And as I was looking into that, I looked at, are there any restrictions from the states, like, agencies or CMS? And like you mentioned, there is no restrictions from the government. So it boils down to the physician perceptions and whether they feel comfortable with, a patient being on solo home hemo treatment. So I think, some of them did mention that if they had the ability to provide remote monitoring and, have like protocols in place, they'd be willing to consider. But I think, like you said, it's really a matter of, physicians feeling comfortable and being afraid of what, all the things that could go wrong with a solo patient, right? Solo home hemo. So
actually, a number of years back, when I was attending one of the DCI medical directors meeting, there was Dr. Rachid Dowie from, I think he was from Saratoga. He had a big nocturnal practice
program
to be centrally monitored. The patients were sleeping while doing nocturnal hemodialysis. They had a contract. There was a nurse in somewhere who was awake and monitoring all the treatments in real time, and if there was an alarm, they would call that patient. If the patient was not reached, they had the number of fire department and everybody, which they rarely had to use, but they had developed that program. So sometimes you have to customize and develop something for your area, if
right.
there's need for it.
Yeah, on that note, it's my understanding though that for nocturnal CMS, FDA does not approve nocturnal without a care partner. So even if you had a remote monitoring, there has to be a human in the house, even if both are sleeping, right? That's fantastic, and I think few programs have that luxury. But I think the reality, what we need to acknowledge, is that having that, live remote monitoring is unlikely to be possible. And that if you train your patients properly, if you select them properly, if you have a team that is closely monitoring, empowering, talking to these patients, we know that they can do very, very well. So I do believe that I just wanted to emphasize it's about the team and pushing ourselves to learn more about this. I wanted to really emphasize the process towards FDA approval, towards what countries that do home hemo better or more do. And I think it's important to look outside and see that we're actually the polar opposite of what these countries that are so successful are doing. I think that's telling a story, okay? They do not have live monitoring. They very much do it the way I presented, which is the historical way of proper training, proper patient selection, and good care.
Yeah, absolutely. I think Beth said in the chat, thank you for being so patient-centered and encouraging everyone to identify what's important to their patients. I would suggest that providers routinely share that My Kidney Life Plan decision aid with patients. Patients can use this to see how things are going, things they value most fit with different options for kidney failure. So yes, that's definitely a great resource. I use it, and Camila and Kunal, do you guys use that?
Absolutely. And there's from the same web page I mentioned before, which is the same one you might be familiar with, Match D. That D is the survey I mentioned, and you can have your patients download My Life Plan. It's for free. They can do it in their smartphone. You can print it, and it really helps match patients' goals and values with the therapy that probably will align better with what they probably will thrive at. So definitely great tool.
And it's also available in Spanish. It's available in Spanish as well.
Wonderful. And I think we have one more question, but before that, I think we want to just make a couple of announcements. And thank you all for joining. This has been wonderful, and we are so happy to see so many of you here. And we're going to have more of those. The next one is going to be on PD. Is it drain pain?
Yeah, drain pain and complication, drain pain. We'll talk about.
Yes, so it will be great. So this will be in October. You'll be getting that flyer out as well. And also, Kunal and Camila, do you want to share the announcement about the fellow abstracts?
Yeah. So I think the call is out, encouraging all the fellows to apply for Fellow Forum for ADC. It's a great opportunity to present interesting cases as an oral presentation. And there's a competition. And if you submit an abstract, you get full, there will be funding for, attending the conference and staying there. And it's just a great opportunity to meet all the leaders in nephrology and present your case and participate and meet your peers from across the country. So please submit cases, interesting hemodialysis, peritoneal dialysis cases through the website for that case competition and other abstract opportunities.
Wonderful. Thank you. And I think the last question was, do you have any experience with a patient having high phosphorus improve when they switched from in-center to home hemo? And how was it very drastic, or they go off binders?
So I would say, yes, I have had the experience. Is it very drastic? No, to be completely honest. That my experience has been, when you start more frequent home hemodialysis, especially short daily, patients' appetites are great. I think we still struggle with adherence to, binders. If anything, their appetite is, amazing. So it could be challenging. I would say the dramatic improvement is with the nocturnal program. I would say it has been amazing. Is one of the reasons why we should encourage a person to actually do nocturnal. One of the things to keep in mind besides blood pressure control. We also have had a great experience with nocturnal in that regard. So
Wonderful. So that's on that positive note. I think, thank you all for joining and hope to see you next month. And hope to see several of you submitting abstracts as well. And, we do have a great program lined up for ADC next year in Kansas City. So hopefully several of you can make it. All right. See you next time. Thank you.
Thank you all. Bye-bye.